Good evening and welcome. My name is Renee Battle Brooks. I'm the Executive Director of the Prince George's County Office of Human Rights. It is my privilege to welcome you all to this evening in another of our Does Your Zip Code Impact Your Life series with the Prince George's County Memorial Library System, our partner. In this series, we have looked at health, education, housing, access to financial lending, and we are thrilled tonight to have a deeper dive into health. We are all in for an important and in-depth conversation about this issue, our health and where we live. We know Prince George's County has areas of wealth and areas of poverty. People separated by only a few miles. How do people in zip codes experience health, access to health care, particularly positive or negative outcomes as compared to people in a zip code in a different area? Tonight, our panelists will take us through data very specific to Prince George's County, as well as talk generally about health access, health inequities, and more. After we have heard from each of them, we are going to join all together for a moderated question and answer period. So please, if you have questions, please put them in the chat and we will get to them during that part of our program. I also want to let you know that Dr. Adela Valdez from the University of Texas, Rio Grande Valley, was one of our panelists tonight, but she has just been taken ill, and so she will not be joining us. We hope to have her on another one of our series regarding health. Before we begin, I want to thank our panelists, their organizations and agencies for their appearance here this evening. This is such an important conversation, and we appreciate you for taking time to be part of it. We have a number of speakers tonight, so let's get right to it. Our first speaker this evening is Dr. Ernest Carter. We all know Dr. Carter here in Prince George's County as he serves as the health officer for the county's Department of Health. With more than 38 years of experience in direct patient care, more than 25 years of experience in the fields of telemedicine and health IT, as well as more than 6 years in public health. He has been responsible for the design, implementation, and management of multiple grants and contracts from various sources, to include the CDC, the state of Maryland, and many, many more. Dr. Carter has served as chairman of the Department of Pediatrics at Washington Adventist Hospital and Mercy Philadelphia Hospital. Dr. Carter holds an undergraduate degree in physics from Harvard College and his MD from Harvard Medical School and a PhD in bioengineering from the University of Pennsylvania. Dr. Carter is married and has raised 2 adult daughters with his wife of 32 years. So Dr. Carter, thank you so much for taking the time to be with us this evening.
Thank you, Renee, and good evening, everyone. It's great to be with you. Achieving health equity is one of the top priorities in public health today. Unfortunately, where you live often makes a difference in your health. We need to change that. Communities that are under-resourced are often the same ones where residents are poor and have poor health outcomes. We can analyze this data about social, economic, and social determinants and needs within a county zip code. The health department has a website called pgchealthzone.org, and I invite everyone to take a look at this website. One of the metrics on there is the Health Equity Index. Now, this index measures the social determinants of health that are correlated with preventable hospitalizations and premature deaths. Social determinants of health are the conditions in one's daily environment that affects their health risk factors. The analysis gives each zip code an index value from 0, which is low equity needs, to 100, which is high needs. For example, right now in the top 4 zip codes with the highest health equity needs are 20019, which is right on the border of DC, 20783 in Hyattsville, 20737 in Riverdale, and 20710 in Bladensburg. Other key zip code level metrics include poverty, income, food, recreational access, the built environment, transportation, and health insurance. The goal is to create better conditions so that everyone has the opportunity to live a healthier life, regardless of who they are or what neighborhood they live in. Focusing on data are key, along with focusing on changes to policies, systems, and environments. This requires collaboration between the public and the private sectors. The health department can't do this alone. In other words, a health and all policies approach infuses health considerations into policy, planning, and program decisions through an equity lens. There are health consequences to policies and laws we make. Not everyone needs the same resources to be the healthiest they can be. However, everyone needs the same opportunity to access the resources they need. Ultimately, this gives us the opportunity to advance health equity. So for now, I'll stop there, and I look forward to answering your questions. Thank you.
Thank you so much, Dr. Carter. That was really insightful. I can't wait for our question and answer period. And so for everyone listening, what we're going to do is each of our panelists will give a presentation, and then at the end, we will all join together. So thank you so much, Dr. Carter.
You're welcome.
We next are going to hear from Dr. Mann. Dr. Mann is an epidemiologist at the Office of Minority Health and Health Disparities in the Maryland Department of Health, and is an instructor in the Department of Epidemiology and Public Health at the University of Maryland School of Medicine. Dr. Mann received his BA in biology from the Johns Hopkins University, his MD from Harvard Medical School, and his PhD in epidemiology from the University of Maryland, Baltimore. Before coming to Maryland for epidemiology and public health training, Dr. Mann practiced primary care medicine in the greater Boston area for 14 years. Also, as part of what Dr. Mann will be presenting, will be answers to questions perhaps that you have that Dr. Noel Brathwaite will be participating in when we get to that part of our program. But let me tell you a little bit about Dr. Brathwaite. He is the director of the Office of Minority Health and Health Disparities at the Maryland Department of Health. Prior to this appointment, he served in several leadership positions in the Caribbean, Florida, Atlanta, and Los Angeles. His research interests include the nexus between place and chronic disease, factors influencing premature mortality in small islands developing states, and linking of healthcare and social care services. These have led to a number of published scientific articles, plus a book chapter on health among diaspora populations. Dr. Brathwaite earned a doctorate from the University of Maryland and pursued postdoctoral studies at Johns Hopkins University and also at the Center for Addiction and Mental Health, affiliated with the University of Toronto, Canada. A shout out to Kyla, who is Canadian. His vision is to transform health and well-being of minorities through data, equity, and collaboration. So again, he will be part of our question and answer period. But Dr. Mann, thank you so much. We are pleased to have you with us this evening.
Thanks very much, Renee, for that very gracious introduction. And I'm very pleased to be invited to present today. There we go. The slides are back. So we'll be talking about briefly about the role of self-determinants of health in the local community on health equity. And getting to the next one. So the outline of the presentation, very briefly, we'll talk about a health disparity causal and data model, which is going to get to the question of why does it make scientific sense that your place matters to your health? Then we'll take a little look at how a couple of key indicators that are somewhat easier to measure, like income and education at the social level, how do they actually relate to health outcomes? And we'll use diabetes as an example. And then we'll look at some data from a couple of zip codes in Prince George's County that actually show the contrast between advantaged and disadvantaged zip codes and how that actually plays out. So here we have a model that I like to use to think about how health disparities evolve, and also basically how just bad health outcomes evolve on a causal pathway from their root causes, which are those social determinants in that column all the way on the left. And you can see education, employment, income, wealth, health insurance, housing, transportation, food security, safety and violence, environment, racism, even more things than on the list. And many of these things vary by place, and sometimes the very most disadvantaged levels of those things concentrate into places even smaller than zip codes. And this concentrated disadvantage, often related to concentrated poverty, is what really creates a lot of these place concentrations of bad outcomes. That whole list in the column ends up determining things like the prevalence and the severity of the causes of disease, what we often call risk factors, but are really more correctly referred to as determinants. And also that determines your access to and quality of both prevention services and treatment services. Then moving another column over, those things determine the frequency of diseases and the severity of diseases. If you actually multiply those two together, you get the rates of things like death, disability, amputations, ED visits, hospital admissions, and the costs that go with those things. So this is the pathway to those things we want to fix on the right, and shows you what their root causes are on the left and how those can be concentrated by your local community. So here, if we look at how income and education, where on the left side we've got on the bottom axis income levels from $15,000 a year to $75,000 a year. And on the right side of the graphs, it's less than high school education to 4 years of college or more. You can see how the frequency of diabetes generally gets better as income goes up, and generally gets better or lower as your degree of education goes up. And we can see that that holds for both the Black population and the white population. But we also see that at any level of income or education, the Black population performs less well than the white population. This is Maryland data from our annual telephone survey. So that shows us, and other kinds of data show us very similar things. There's this clear relationship of different social factors to health in analyses that look very similar to this. Now, in addition to that finding, we can see here that the likelihood that you're in either that low income of 15,000 or that high income of 75,000 is really different by racial ethnic group. So here we can see that the in the kind of light green line, at the 75% or 75,000 income level, 47% of the white population in Maryland is at that level or higher. Only about a quarter of the Black population has that income. Whereas if we go down to less than 15,000, we see that that's 5% of the white population, but about 13% of the Black population. So the minority population is more likely to have the more disadvantaged income levels. And that also holds, as we see in the other panel, for the education levels. So I thought we'd turn to looking at a couple of zip codes. And so I chose to look at 20743, remembering that that was in fact the site of the health enterprise zone that Dr. Carter managed so successfully back between 2013 and 2017. And thought to contrast that, I'd pick something in the south of the county, which is usually where we get a little bit more affluent suburban communities, and pick 20613. And so those are the two we're going to be comparing in a couple more slides. And so here we look at what do those zip codes look like from some economic parameters and some demographic parameters. So Prince George's County as a whole, median household income of 85,000, an average household income of about 103,000, and about 10% of households have an income over $200,000. In 743, we can see that it's much lower than that for the median income, the average household income, and the percent of households that have very high income. Then if we compare that to 613, we see a much higher median income, a much higher average income, and 20% of the households over 200,000. And so if we take ratios of these things, the income levels in either of these ways of thinking about kind of where the middle is, about twice as high in 613 compared to 743, 5 times the percent of the population that's in this high income level. And then if we look at how that relates to the racial ethnic distribution, we can see that certainly the white population in 613 is 35% of that zip code, but only 4% of 743. So that brings us back to that correlation of lower income with minority status, which really has no valid reason to exist other than the past and current injustices that have existed in our society. So then how does this translate into health outcomes? So here we're able to look at the hospital encounters, which combines emergency room visits and hospitalizations together for some different conditions. And here we have the counts of those, but we also wanted to convert them to a rate per 100,000 people, because comparing the rate allows us to compare things without getting confused by the fact that different places have different sizes of population. So looking down this list of diabetes, asthma, high blood pressure, chronic kidney disease, mental health disorders, and drug use disorders, we can see in blue we have the rates here in Prince George's County. For zip code 743, all of the rates are higher, that's why they're in red, than the county level. And as we go down here, all of these are lower than the county level in 613, with the exception here of high blood pressure, where they're pretty similar. And so we can see that the ratio of the rate in the county that has better social determinants compared to the rate in the county with the worst social determinants looks like it's about 1.5 times worse, or 1.5 times worse. That's the ratio of this one to this. The red to the green. So the social determinant, worst social determinants, about 1.5 times worse health outcomes for many of these. Not quite so high for high blood pressure, but up to 2 times higher when we get to the outcome of drug use disorders. So here we see that relationship of the worst health outcomes with the worst social determinants of health. So one might think that this analysis is perfectly straightforward. So I did want to include this one slide to illustrate that it's not always as clean cut as that analysis I just showed. This looks at heart disease hospital encounters, and this time it's per 1,000 population, since heart disease is much more common. And this is looking on the bottom axis by the percent poverty across a large number of zip codes all across the state. And what we see here is that the purple line shows a little bit of a relationship where you do get worse outcomes at the higher levels of poverty, but you can also see a lot of vertical scatter in these dots. So if you go out to the 35 to 40% poverty range, you get some zip codes that are down around 60 for the rate and some that are up to 210. When you go to only 5% poverty, you can see there are a lot of zip codes that are around maybe a rate of 10, but some are still up at that 210 level. So trying to figure out how this predicts for individual zip codes is a little more complicated. I think we have some refinements to do in how we work this analysis at the health department, and that'll be part of the work of the new Maryland Health Equity Commission. So I'm looking forward to working with a lot of partners to try to help improve how we can do this analysis, the kind of data that we have, the detail we have, and getting some more precise and useful benefits out of this kind of analysis. So my last slide just kind of summarizes what we've said. Health problems and health disparities travel in a causal chain from the social determinants and social factors to disease risk factors, to disease frequency and severity, and ultimately to the outcomes we're always trying to improve. Low income and low education are certainly causes of poor health outcomes and often are causing many of the other adverse social determinants of health. And concentrated poverty that can exist in areas even smaller than zip codes can create even more extreme disparities than the ones we've been able to illustrate in these data. And that concludes my presentation.
Thank you, Dr. Mann. That's a lot of food for thought and some questions that I'm sure our audience will have. So thank you for that presentation. And we will see you when we bring everyone back together. Our next speaker is Dr. Stephen Thomas. Dr. Thomas is the director of Maryland Center for Health Equity and a professor at the University of Maryland, College Park. Dr. Thomas has received numerous awards for his professional accomplishments, and over the years, his work has become recognized as one of the scholarly contributions leading to the 1997 presidential apology to survivors of the syphilis study done at Tuskegee. His current research focuses on the translation of evidence-based science on chronic disease into community-based interventions designed to eliminate racial and ethnic disparities in health and healthcare. More specifically, he is focused on understanding how social context shapes attitudes and behaviors of underserved, poorly served, and never served segments of our society toward participation in health promotion and disease prevention activities in barbershops and beauty salons. Dr. Thomas is particularly interested in how the legacy of the syphilis study at Tuskegee, and that was from 1932 to 1972, has impacted trust and influenced the willingness of African Americans to participate in medical and public health research. So, Dr. Thomas, thank you so much. We look forward to your presentation.
Well, thank you. It's an honor and a pleasure to be with you this evening, Renee. Battle Brooks, what an interesting topic. The previous speakers have kind of set the stage. And so, I'm at the stage of, well, what are we going to do about it? I mean, nobody wants to live in a hot zone. Do you want to live in a hot zone? Nobody wants to live in a food desert. Do you want to live in a food desert? That's right. So in public health, we do the analysis and all the data, and we show the connection between your zip code and your health. And there can be unintended consequences. If you're going to open up a business, or you're going to move your business to a place where you see, oh, that's a food desert there. Those people suffer from all these chronic diseases. Where's my workforce going to come from? Unintended consequences. But people, I'm a baby born in 1953. I'm telling my age here. So I remember when my parents lived in the ghetto, okay, where Black people, physician, janitor, unemployed, guess what? Lived in the same projects. And then we know history, and some of you have lived it. Okay, then we can move out to wherever we wanted to live. Redlining. We're seeing all this now in the papers today. We've been studying this for decades. Okay, that's why we say health disparities, not just health difference. I want you to put your hand up when I have 2 minutes. I just want to tell a little story here about why the barbershops are so important. That's why these polls are here. These are the metaphor for going into those very zip codes we're talking about and engaging those communities in health promotion, disease prevention, in translating the science of medicine and public health into culturally tailored, community-based interventions. And you know what we can do, Miss Renee? We can tell the people, you got the power. If the pandemic has taught us anything, is that there were systems across the country and somebody with the biggest microphone in the world who said this was all a hoax. Who said it will go away when the weather gets warm. So we were behind the curve from the very beginning. And many of our communities were being marinated in misinformation even before we had a vaccine. So let me come to the finish line real quick for you. You know that no self-respecting Black barber would ever say, I'll get you in and out in 10 minutes. And it doesn't matter how much hair you have. You're going to be there all day. So why not go where people already have trust? Why not transform our barbershops and beauty salons into trusted information centers? And on May 17th last year, we did the very first COVID vaccination in a Black barbershop. Yes, Dr. Carter, in Hyattsville, the very zip code you were talking about. And because we're inside the Capitol Beltway and 9 miles from the White House, guess who showed up? Washington Post, New York Times, ABC, NBC, Wall Street Journal, USA Today. Those stories ran, Miss Renee, and in 48 hours, I got a phone call from the White House. And they said, do you think you can scale this? The rest is history, my friend. We have 1,000 barbershops and beauty salons across the country being trained in our rapid response training for barbers and stylists. It comes right out of the state of Maryland. It's called HAIR, Health Advocates in Reach and Research. And we are training our barbers and stylists to become, you ready for this, Renee? Certified community health workers. We have 3 of our barbers are certified community health workers. You know what that means? They're frontline health workers in the very zip codes where we need to save lives. We want to do more of this. And as the surge threat diminishes and everybody wants to go back to their corners and business as usual, hey, here's a message from the barbershops and beauty salons. Nobody wants to go back to normal, because back to normal, far too many Black and brown people live sicker and die younger for all the reasons the previous speakers just talked about. So if you can't geographically move? How do we make sure that these communities, now that we have all the data and can pinpoint right down to the zip code, how do we make sure that we take advantage of what Dr. Carter knows from the health enterprise zones to actually move the needle? We're doing that right now with our barbers and stylists. And with that, I'll turn the floor back to you.
Why, thank you, Dr. Thomas. That was really inspiring. We're going to have lots of questions about, what other industries, right? But we have a lot to talk about. So thank you for that. We are next going to hear from, and we welcome Doreshia Hines. Miss Hines graduated from Brooklyn High School of the Arts. And let's see, maybe if she is not with us right now, we can definitely skip. I tell you what. Nope, here we are. Great. Welcome. All right, we'll try that again. Miss Hines graduated from Brooklyn High School of the Arts and went on to obtain her Bachelor of Arts from Hunter College in New York City. She has held positions including President of Global Medical Brigades, Hunter College Chapter, which is an organization that traveled to various countries to provide healthcare services and health education to communities. She obtained her master's in business administration and a graduate certificate in healthcare leadership from the University of Delaware. After working in healthcare administration, Ms. Hines obtained her nursing degree and has worked as a registered nurse in the intensive care unit in several facilities, including Johns Hopkins Bayview Medical Center, Staten Island University Hospital, Long Island Jewish Medical Center, Baylor, Scott and White Temple, and University of Maryland Medical System. She is passionate about the health of the communities she serves and helping to close the health equity gap. So Ms. Hines, thank you so much for being with us. We look forward to hearing what you have to say.
Thank you. Good evening, and thank you for having me. As Renee mentioned, I am from Brooklyn, New York, and from Brownsville, which is one of the poorest neighborhoods in Brooklyn. And I've been working in Baltimore City for the last 2 years. And what I have seen is that a lot of the issues that we have in Brooklyn are mirrored in Baltimore City. So these issues span across the nation, and social determinants of health, as some of my colleagues have mentioned, really play a factor in the health inequities that we see. So today I just hope to share a little bit of my lens as a nurse and a paramedic about things that I have seen that contribute to health inequities and some of the things that I can do as a frontline healthcare professional to help close the health equity gap. So as a paramedic, many people assumed that we went to car accidents, trauma scenes, gunshot wounds, and victims, but really, a lot of the patients that I saw were asthma exacerbations, diabetic emergencies, and hypertensive emergencies. Overuse of the emergency system because of poor management of chronic illnesses. And this is for a number of reasons, including environmental factors, financial hardships, transportation, and access to care. I want to share a story about a patient that I cared for who had an asthma flare-up, a 12-year-old. And as a paramedic, we have the unique opportunity to go into someone's home when we care for them. So as soon as I walked in, there was a noticeable issue with the air quality, ventilation, and there was mold in the home. So while we could take this patient to the emergency department and acutely manage their illness, if we discharge them without the proper resources, we're sending them right back to the same environment that caused the issue. So this just leads to readmissions, rehospitalizations, and we're not getting to the root cause of the issue. So as a paramedic, I was able to see that on the front end. And then as a nurse, we are able to see how we can impact health equity once our patients are in the hospital. So unfortunately, once the patients get to me in the ICU, they are past the stage of prevention, they're in crisis, and we're managing that illness. But the best way that we can prevent them from coming back with the same issues is, again, getting to the root cause of what got them here. So as a nurse, I have the unique opportunity to talk to my patients and do initial screenings to find out what is causing medication non-compliance, what is keeping them coming back and forth to the emergency room. And a lot of patients report issues with transportation to appointments, and high prescription costs. So again, if we don't connect them to the resources while they're in our care and they go back to their communities without the tools to be successful, the cycle of admissions and health inequities will continue. So as a nurse in integrated care models at the facilities that I've worked at, screening is really important in partnering with social workers, case management, outpatient resources, primary care services. Those are all things that we can do to help close the health equity gap. But those screenings of asking questions, are you food insecure? Do you have issues about where your next meal may come from? Are your prescriptions too high? Is there a reason why you didn't take your medication? Are you taking the right dosage? So from a clinician standpoint, we definitely have the opportunity to impact it, but it's really a larger issue that goes beyond the medical management of the disease. And we have to look at the social aspects surrounding the person and what's continuing to have them in these situations. Cancer screening as well is a big disparity amongst our population, particularly African Americans in underserved communities. So today I just want to share a quick story before I close about a cancer patient that was very near and dear to my heart, which was my mom. So she unfortunately passed with breast cancer in July of 2021. Her initial diagnosis was in 2014. She did all of the things right. She did yearly mammogram screenings. She went to the doctor. She had good health insurance, access to care. When she received her mammogram in 2013, she received a vague letter from the doctor to follow up in 6 months as there may be a low suspicion of malignancy. No direct instructions about how to address the issue, and it could have gone unnoticed. Thankfully, my mother expressed to me that she saw a lump in her breast. We investigated it and we were able to advocate. And within a week, we were sitting in the doctor's office with a stage 2 breast cancer diagnosis. So had we waited 6 more months, the outcome could have been different. While she ultimately did pass from metastatic breast cancer, as a lot of African Americans do, die of breast cancer and all kinds of cancers at higher rates than our counterparts, the initial screening and the initial education to get proper care and quality care is important to outcomes for our patients to continue to survive, prevent, and find cancers early that can be preventable. So while my mother received excellent cancer treatment throughout her time, the initial diagnosis, we don't know if it would have changed the outcome. We don't know if a sooner diagnosis might have changed things, but it just continues to allow us to acknowledge that cancer screening and preventions is one of the keys to helping communities close health inequities gaps. And that goes back to access to healthy food, hypertension management, stroke, and all of the factors that in their environment that can contribute to higher levels of death. So some of the things that I believe can be important to advancing health equity is the continued integrated models of care, partnerships within the healthcare system to ensure that prior to discharge, we're connecting patients to the appropriate resources that they need, pipeline and youth programs to increase African Americans as well as other minorities in the healthcare workforce are important to advancing health equity and care, as well as community partnerships. So trust in the community, screenings, and continued partnerships to allow everyone to get the information that they need to advance care. So I thank you so much for having me. I appreciate the time that you gave me today to share a little bit about my experience with patient populations and health equity. Thank you.
Thank you so much, Ms. Hines. That was very, again, insightful. I love how each of our panelists brings something through just a little different lens that really helps us to think. So thank you. And we'll have you back in just a moment. Our last, but certainly not least, panelist this evening is Dr. Laundette Jones. Dr. Jones received her Bachelor of Science in Chemistry from Morgan State University, a PhD in Environmental Health Sciences from Johns Hopkins School of Public Health, and most recently, her Master's in Public Health from the University of Maryland. She is currently an assistant professor at the University of Maryland School of Medicine, where training, education, and research are among her professional activities, while her early research career has focused primarily on the laboratory bench, or if I was in England, I would say laboratory bench, studying genetic and environmental causes of breast cancer. She has always had a heart for community connections. Her unique background in the biomedical sciences and public health guides her current research efforts to address health disparities through understanding the interplay of biological, environmental, and social factors. Currently, she is building meaningful and trusting relationships between diverse groups who seek to co-generate knowledge to produce comprehensive and context-specific strategies for reducing health disparities. This work also translates into service at her multicultural church home, where she partners to build bridges to the community. Finally, Dr. Jones is a native of Prince George's County and currently resides in Baltimore City with her husband of 22 years and their 2 teenage boys. So thank you so much for joining us, and we look forward to what you have to tell us.
Yes, thank you so much, Dr. Battle Brooks. I am so pleased to be here. As you read, I'm a native of Prince George's County, and really this topic about the zip code matter kind of hit home to me. And I recognized many of my prior colleagues had really set the stage for understanding the impact of zip code. And I thought through my talk today, I would share a real personal experience of, really going through Prince George's County and then in Baltimore City and the zip codes I've experienced, and then in with some other things that I feel is important to add to the conversation that also matter. So in the 70s, I grew up in a zip code 20708. For those of you who are familiar with off of Route 197, at the time, it was a neighborhood called Pumpkin Hill, which later became South Laurel Drive and is now the Villages of Montpelier. But essentially, when these apartments started, they were what I would say the public housing. And in this housing, it was low income. I'm a product of mom and dad, 3 children. I'm the youngest. Essentially, my dad didn't make over $25,000 a year, and the statistics my colleague Dr. Mann was showing, like we were around that $10,000 range around that time. And so you can imagine with that low income, you miss a paycheck, it's all over, right? And that's really what happened to us. So I would say throughout my initial early years, we had various bouts of homelessness, times where the government was furloughed. My dad worked for the National Park Service. And, a couple times they were furloughed, and where would we go? So essentially, the zip code that we were in really did provide the low amounts of rent that we could pay, but we didn't even have enough to pay that. And so, it was really not until I got into high school where the housing started to become stable. But there was a stretch of time when I was in middle school where we actually lived in Greenbelt Park. For those of you who are familiar with PG County, and I don't even know what the zip code was there, but I know that I attended Greenbelt Middle School. And, for those who ever visited Greenbelt Park, you know that there's this long winding road to actually get to, the campsite. And, my dad, who thankfully he was a member, he actually worked for the National Park Service. We were actually able to stay there for free. So it goes to what I'm going to say later about, the zip code matter. I think it matters. It also matters having connections, having opportunities. And that opportunity for us to stay in a tent, which we went camping every year, really mattered for us and really offered the stability for me to actually go to Greenbelt Middle School. Didn't know my address, didn't know my zip code, but we walked that winding road, my brother and I, to get to school. And so, like I said, in high school, that was the time when I was actually able to live off of 64th Avenue, Landover Hills, in the zip code 20784. And I was really excited because now, I'm finally arriving in high school. For me, I really, really wanted to be a secretary because I love to type, right? It's amazing how God works. I'm here now. But it was during that time, where things started to get a little bit stable. And I was in high school, and my softball coach had asked me, "Hey, you're about to graduate. What are you going to do for, going to college?" And I said, "Well, my parents, they didn't have a lot of money." And I tried to explain to him, and he looked at me like I had two heads, really. And he said, "If anybody should go to college, it should be you. You're about to be salutatorian of this school." And so with that beginning of the conversation, he directed me to counselors. And just this person who was placed in my life, Mr. Bradford, wherever you are, my math teacher, I am so grateful for you to directing me to actually having counselors, to get a full scholarship to Morgan State University, to study chemistry, to then proceed to graduate school at Johns Hopkins University, where I was able to get my PhD, as you heard, in toxicology. And so fast forward to now, I'm, as you know, with a husband and two sons, and we live in a zip code in Baltimore City, 21229. And unfortunately, as some of you may have heard about Baltimore City schools, some of the schools are really challenged. And we live in one of those areas. And so really, when it comes to, the housing and the contributions to the school settings, it matters where your zip code is. So I just wanted to flip now in the last half and start to talk about zip code. It does matter. But what are some of those other things? Because technically, as you've heard, through the homelessness, I should really be a statistic. So what were some of those things that made a difference? Well, I mentioned I grew up in Laurel, and there was a place near the Laurel Boys and Girls Club called Help Laurel. And it was a place that had free stuff, clothes, everything. Those kinds of places, and I don't know who led it, but we were able to not, have to worry about not having money to shop for clothes, but they had the free clothes that we could use. Moving along, there's places like, a lot of people complain about the government cheese. We love the government cheese. We created all kinds of things. My brothers were very creative. And those were the kind of things, that sustained us. This store called Basics that was in Prince George's County. I tell you, it was opportunities. Everything was black and white labeled, but those were some of the things that, we ate. Now, I would, if I had more time, talk about, of course, the stable,
Take the time. Take the time.
Yeah.
It's important.
Well, I did want to share that, a lot of the foods that we were getting, obviously the cheese, which was free and we loved it, but we're learning now about, the processed foods. I think they have a special word for it now. Is it called shelf stable foods?
That sounds about right, but
Yeah,
I'm not,
yeah.
that does sound
There's a
topped with
special
chemicals, right?
Yeah. But there's a reason why they're stable fresh, and because we couldn't afford a lot of the fresh fruits and vegetables that a lot of people are saying we need, we couldn't afford it. And so we ate a lot of boxed foods. We ate a lot of canned foods because they're shelf stable. So down the road, what that does to a person's health, that's important too. I want to, end with talking about what I'm doing now. So I recognized there was a sign that I used to walk by all the time when I had my laboratory, and it said, and it was a quote that said, "Discovery is seeing what everyone has seen, but thinking what no one else has thought." And it was it was a quote that stayed with me for a long time, because now fast forward, I recognize that I've been in the laboratory, I've done a lot of work. And by the way, the reason why I left the lab is because I met a survivor for the first time as a faculty studying breast cancer, as you mentioned. And I'm really sorry to hear about the prior caller's mom. Um, but in the biomedical training, we don't often come in contact with the patients, with the survivors of the disease that we're studying. And I was able to meet a wonderful lady. Her name was Marlene King, and she transformed my life, because here I am studying the mechanisms, the molecular mechanisms, for those with the biological backgrounds. You know what I'm talking about. These mechanisms of cancer. But here's a wonderful breast cancer survivor who taught me about health disparities, who taught me that it's not just, finding that genetic factor, but it's also about access to health care. It's about, do we even have the transportation to get there in the first place? And so that quote, discovery, seeing things that everybody has seen. I've come through a background that I used to be, pretty much embarrassed about and not really talking about. But I recognize now in this public health space, having seen the disparities side and the struggles that my parents went through just to, move forward. I recognize that I can see the inequities, but having now arise to where I am as a faculty, I know the resources. I know, a lot of connections, and that's really what we're doing now. My husband and I, who he actually developed this this group called the Chesapeake Cohort, and it's known as the Community Comprehensive Health Disparities Research Team, to which we're very grateful to have Dr. Noel Brathwaite actually as an external advisor for. But we're bringing together many, many stakeholders, transdisciplinary teams from the communities, from the academics, from faith-based institutions that are coming together to really devise context-specific solutions and comprehensive solutions that are going to address health disparities. And most importantly, listening to the voices of the communities, not after we've figured out an intervention or decided research, but from the start. What are the things that are important to communities? And so is very novel. It's very exciting, but I believe it's what we need. We're living in a day, as my prior colleague mentioned, of mistrust due to COVID, but through history of a lot of different factors. And so right now, we really need to do this together. And what better way to do it than to start to have these conversations? So I'm really grateful that you and your colleagues are starting to bring these conversations out into the open, so that we can really find solutions together, because I really feel we are better together. Thank you.
Thank you so much, Dr. Jones. Yeah. As everybody's coming back on for the discussion, I love how you framed, that you just can't have research in a vacuum, that you really have to, have, for lack of a better word, the end user's input, right? You have to have the community's input. And it made me really think about algorithms or processes. Now, I've never gone to medical school, but I imagine, it's called a practice for a reason. And, there are processes and things that are taught. And I remember not so long ago reading an article about some young folks that were currently in medical school and how some of the processes that were taught had embedded within them sort of racism, but not knowingly, if that makes sense. Am I making sense to anyone here on the panel? And so I started thinking about that, and just follow me. It may be a leap, but the race norming issue within the NFL. And has everybody followed sort of the race norming? This is the head trauma that the NFL players had, and the suing of the NFL for not having the correct protective helmets. And fast forward, I think it was last year, maybe it was in 2020 in June or thereabouts, it came out that some of the African American players who were trying to get the settlement of the money weren't getting the same amounts. And it turned out that within this algorithm, within the medical diagnosis, or those that were doing the assessment, there was a race norming that had factored in it, that if you were African American, you weren't as smart. So why should you get as much money? So in my roundabout way, I'm asking, how do we change this? If it starts sort of with faulty or flawed ways of some processes, and again, algorithms that seeming to have innocent outcomes, but are built in it, things that have disparities. Can somebody talk to me about that? What do we do? What does it look like? How can we change this? Not all at once. Anybody that wants to jump in.
I'll jump in. You know, as you were talking, it reminded me of what's happening with the glomerular filtration rate, the GFR. So what that is, what we're finding is there's a lot of different algorithms that were developed to correct for African Americans. And when I get a chance and finish talking, I'll find the paper that's up there. But even here at the University of Maryland, they've actually moved to remove that factor. So you were talking about the factor in terms of, you know, knowledge, but there's actually medical factors that I even learned about, you know, in terms of hysterectomies and things of that nature. So I'm going to find that paper. I think what you're getting at is something that our school is trying to do, and trying to revisit a lot of these algorithms that were developed long ago, and trying to understand, do they matter? Do we need that corrective factor that we're using for the African Americans, and why we're using it? And so that one factor, because I know that it took a lot of work through a lot of people within our institution, and not just Maryland, but across you know, the U.S. that are trying to correct these factors. So I'll see if I can find that paper.
Wonderful. Yes, thank you. Would anybody else like to comment generally about that issue?
I will. Can you hear me? I just want to say one thing about that. We really have to be at the table when the algorithms are being created. And this is really important now, especially in the digital age where you have artificial intelligence and machine learning being able to recognize patterns. And if you don't put in the culturally specific pattern, then it'll default to who built the algorithm. And it turns out that not a lot of us do that. And not a lot of people who are affected primarily by the system are putting input into how these algorithms should be written. And to be perfectly honest, you know, as we start to build systems in public health, that's going to help people, and we know that that these systems, everybody can talk to their phone, and the phone can doing the AI to make sure you get to the right thing to buy. It actually, we could be proactive in making sure that the patterns that are showing up in our underserved areas and that need to be connected to resources are recognized by systems. We got a lot of work we can do in this space. And so when you look back at what happened at the NFL, that algorithm, like you said, was a faulty algorithm. If we had been at the table, we could have said, that's wrong. Get rid of that. This is the new algorithm. So you got to have people in the spaces, all spaces. And we have to make sure we have the capacity building at the Howard Universities, at the Morgan States, you know, to make sure they're getting to the field at the University of Maryland and at Hopkins. But we have to have representation from the community in the spaces that are going to make sure that the representation is there. And those are people who coming out of the zip codes we're talking about. We need to take people out of those communities and start lifting this up. because that zip code will get better when we take the people in the community to get them to the point where they improve their community with the cultural sensitivity in it that they already have, with the knowledge that they already have. So that's a big lift, but that's something we have to do. It's critical in making this difference.
Yeah, and Dr. Carter, when you say that, I think about how really we as Americans, most of us don't realize it, but we are competing on the world stage, especially when it comes to sort of the hard sciences, I call them, right? And as you said, we have to ensure that the education we are giving everyone meets that standard, where in the maths, the sciences, that we can compete, and then have a place at the table, because right, we have to. So thank you. Dr. Thomas, Dr. Brathwaite, Dr. Mann, anyone want to offer anything on this particular subject?
I'd just make the comment that if you go back about 150 years, concepts of racial superiority were mistakenly accepted science. They were claimed to be justified in the Bible. So we've got an awful lot of wrong thinking in our past that we have to fight against and overcome. And unfortunately, a lot of people who don't want that to be wrong. So they fight against that. So we've got a lot of work to do.
Yeah.
I would think that individuals who are aware of the faulty algorithms have a responsibility to air their views and to speak truth to power. Very often this is not done. So our own scientists, our own informers remain silent. And that silence is very often to the disadvantage of the rest that we want to lift up. So it means that we might need some more advocates, some more writers of truth, and also some more mechanisms for expressing those truths. We might not always have access to the Washington Post, or we might not always have access to the New England Journal of Medicine, but there are forums where the advocates of these faulty mechanisms can be spoken to. We have, even through the, I don't know what position the National Medical Association took on that issue. And very often the voices of those organizations are not heard. And even in the area of clinical trials, this is another area where the voices of the researchers and the academic so-called intellectuals can come and present to the general public what is lacking in those kinds of critical areas, whether it is the social scientists and our standing leaders. So I think there need to be an intentional voice of individuals within the community that is disadvantaged to speak clearly to powers and see that change takes place. So I think that's one of the critical links that is missing, where the voices of the representatives or so-called intelligentsia are very often silent.
Yes, thank you, Dr. Brathwaite. And Dr. Mann, your comments. Thank you very much. Dr. Thomas.
You know, the history of racism and discrimination in medicine and public health would be easy to ignore if it wasn't so well documented. So our people have legitimate reasons for their distrust. It was the pandemic that pulled the curtain back and exposed all of these social determinants of health. But you know, Renee Battle-Brooks, we moved the needle. At one point, Prince George's County was leading the state in COVID infections. Now our rates are some of the lowest in the state. That didn't happen by accident. We did some things. Now here's the question. Will we continue to do those things? Because we turned a big ship fast. We put up rapid response teams. We went into the community. We made it easier to get telemedicine. We made the vaccine free. We did a lot of things right. We did some things wrong, but a lot of things right. We can fix the things we did wrong, making sure people in those zip codes have access to the internet. That's a big key. Making sure their phones, hey, Dr. Carter and Dr. Braithwaite, Dr. Mann and Dr. Jones, the folks in the neighborhoods I work in, these are poor neighborhoods. They got better phones than I do. It's the TV, it's the telephone, it's their everything. But they have not unlocked the power of this phone to monitor their own health, to promote their own health, to get reinforcement to do the right thing, to have trusted information on their phones. We can change that. So I think that we need to do what we learned through the pandemic and hope that the resources that are in place don't just go away and back to the silos. Dr. Carter, we broke silos. We got people working together across silos, Dr. Braithwaite. We got private industry, public health, medicine, all in one big collaborative, which was started right here in Prince George's County. I call it the solution space. So our hope is that the convening of that group doesn't just go away as the surge and threat is off the front pages. We know what to do. Let's continue to do it and be a national leader right here out of Maryland.
Yeah, I love that. Does somebody want to comment before I?
Yeah, what I would say is that when the newspapers are silent and when the other means of communication are silent, it doesn't mean that the leaders of the communities should be silent. So when the disease, in terms of its intensity, passes, we still have work to do. And very often, that work might be done in silence, but it surfaces at some critical point. And one of the things that I think we can do in silence, when the newspapers are, the reporters are not there, is to continue to deal with what I think very often we have not highlighted is individual responsibility. Even though we have corporate partnerships and those kinds of engagement, very often we find that there's a gap in individuals accepting some aspect of responsibility for their own health. So I think undergirding Dr. Thomas is getting down to where families, even in poor neighborhoods, and in poor neighborhoods, there are some wealthy communities within zip code 20783. So all of 20783 is not poor. All of 20783 is not inhabited by multi-family homes. They are single-family homes. And so the one of the things that I think we might want to highlight is the action of communities by community members in changing the systems. And I think that's a critical point that we very often miss: individual responsibility.
Yeah, I love that you said that. I also, I was thinking as everyone was talking, and I think individual responsibility is important. I was thinking about policies, so maybe not algorithms, but policies, particularly when it comes to sort of transplants. So let's take, for example, kidney transplants, right? So maybe some of the policies are you have to eat a certain amount of fresh vegetables, however many times a week, and you have to go to dialysis, right? When you start talking about zip codes, if you're in a food desert and perhaps your grocery store is the 7-Eleven, seriously, then how are you getting that fresh, how are you, if you are the sole breadwinner in your house and dialysis takes 4 to 6 hours or whatever it is, and you don't have a car and you have to take the bus, and it's either losing your job or going to dialysis, so there are built-in disparities. How do we change those sort of policies that dictate who gets? Because there are always going to be those that have taken individual responsibility, but part of that responsibility includes caring for others. Talk to me about that.
I was listening to a program. I was listening to a program this morning, and it struck me that if we don't have food, is it possible for us to grow food? And in the urban community, they're referencing Baltimore, where in the urban community, they are beginning to produce food. Very often we are consumers of food, but we haven't turned the deserts into what in Israel, but they turn the deserts into bloom. So could it be that within these food deserts, the production of food has not taken root since we are consumer oriented? And so in Park Heights, we are watching Park Heights from, I'm dealing now with the Office of Minority Health. We are watching Park Heights as a place where we can invest funds, and it is competitive, but we can also target. They have a plantation in Park Heights. It's called the Urban Garden. And I think that in many of these communities that we consider to be food deserts, we are depending more on the delivery of food rather than the planting and production of food. There could be community gardens in food deserts. So I think that sometimes within these food deserts, efforts can be made to plant foods. An individual who might be on dialysis and who might reside in those deserts, if they can, even in an apartment, there are some apartment buildings whereby foods can be planted. And I think that might be some action that we can take another look at in promoting the modern agriculture of plants, planting of food that can be of benefit to the communities.
Yeah, thank you. That's a great point, Dr. Brathwaite. Anyone else wishes to comment? Oh, you're muted, Dr. Thomas. I'm good at reading.
There we go.
Okay.
There are little promising programs all around. We have an initiative in Temple Hills where our students were involved in transforming a vacant parking lot full of trash over a 4-year period. It's now an urban farm, Dr. Brathwaite, in Temple Hills, Dr. Carter. Last growing season, we grew 1,000 pounds of produce.
Wow.
All donated to the Catholic Charities Kitchen that actually produce food to feed the hungry. That's a little example. That's a little class project. What Dr. Brathwaite and Carter are talking about is scaling with real resources, not volunteerism, not a class project. And that requires long-term commitment. And so we've got an army, Dr. Carter, that has been built around the pandemic all across the state, Dr. Brathwaite. They want to stay together. They need a charge. They need an action plan as we move into this living with it. It's still a pandemic, but everyone's saying, how do we live with it? So here at the university, our students have been building Corsi Rosenthal filters. The question you have to ask yourself while this pandemic is still going, who are you sharing air with, Dr. Jones? Dr. Mann, who are you sharing air with? Do you know if they've been vaccinated or not vaccinated? Well, COVID is an aerosol. Have you ever walked into a room where somebody's been smoking? They're not there, but you smell the smoke. Or someone with heavy cologne or perfume and you walk behind them and you smell it. That's an aerosol. That's COVID. You just can't see it or smell it. Well, these Rosenthal boxes, filters, will take COVID out of the air. And we're building them with duct tape, Dr. Carter. And guess what? It actually works. So we're giving them away. Oh, here's the other part. We took them to the local middle school, College Park Academy. And Miss Hines, the 6th, 7th, and 8th grade science class, you know what they did? They decorated the boxes. So now they're a piece of priceless art. And we've been delivering them to the elderly. We delivered one to an 85-year-old woman today. We're delivering to barbershops, beauty salons, funeral homes, churches, anywhere where people are congregating. Guess, look, the masks are coming off. How are you going to protect yourself? Who are you sharing air with? We love to give the instructions about these Corsi boxes, Dr. Carter, because you can come together as a church group, a choir group, a gathering, and you can build these things and give them away. It takes the pollen out of the air. It actually is simply a better air filtration. COVID is teaching us this lesson. It's not going to go away. COVID is not going to go away. We're going to have to live with it. Meaning, how do we live with a novel virus that's an aerosol spread by people with little or no symptoms? It's one of the first infectious diseases spread by people with no symptoms. So you can't look at someone, Renee, and tell who you're sharing air with. These filters can help improve air quality. Let's get people involved in building them. It gives them something to do. Because right now they don't know what to do and they don't know who to believe.
You're speaking my language, Dr. Thomas. You're speaking my language. We're going to have to talk offline. I love it.
So I can put a comment into it, and I'm going to assure Dr. Thomas that I'm still wearing my N95 mask when I'm in proximity to other people for all the reasons you just stated. So as someone who sees the data, I'm being careful still, which is, I think, a smart thing to do. The issue of people trying to do the right health behaviors. We had a phrase we've used in the health department about trying to make the healthy choice the easy choice. And in one of my many roles, I actually do some teaching of health behavior change theory. And to me, it kind of boils down to you got to know what you're supposed to do. You got to be motivated to want to do it, but then you got to be able to do it. And so at the end of the day, can we create the environment where people have the ability to execute the personal responsibility we'd like them to take? And so I think we do have to make the investments that Dr. Thomas was talking about in communities to put that capacity and that capability in place for people who've had massive barriers to doing the healthy thing before.
You know, Dr. Mann, when we were in the barbershops and salons in the early days before there was a vaccine, we taught the barbers how to use their phones to do interviews with people in the chair. And they would just simply ask a question: have they been vaccinated? Or would they be willing to take the COVID vaccine once and when it becomes available? And have they taken the flu vaccine? And the stories that came out are amazing. Well, here's one of the things that we've learned through the pandemic. Hesitancy does not mean never. Dr. Carter, we had people who showed up to the barbershop on vaccine day hesitant. And they left hesitant, but they got vaccinated. They didn't come to a clinic. They came to their local barbershop. We had music with a DJ. We had catered food. They were coming to a party. And then we said, oh, by the way, the physicians and nurses are inside. You can give and take all your questions to them. And because it was convenient, and because it was easy, Noel, and because they were there and other people had lined up and grandmothers were there with their 12-year-old grandchildren to get them vaccinated, guess what? Mr. Hesitant left hesitant, but vaccinated. So you don't have to change people's worldview, but you do have to treat them with dignity and respect. And in the settings we're talking about where people come, Renee, you probably have somebody you go to and you trust her, don't you, or him, with your hair. You don't just let anybody touch it, meaning they come back time and time again. They have relationship. And when we make our barbers and stylists and train them to become certified community health workers, now we have frontline health workers right there in the neighborhood. I think that's a way to go. That's what we want to try to do.
Yeah, I love that model. Dr. Thomas, for those that are listening that may not understand the significance of barbershops or beauty salons, can you just explain sort of why that is so significant? What does that actually mean?
You know, I've asked myself that question a couple times because I was contacted by the Physicians Weekly. And so this is kind of captured people's imagination. Most people don't know the history of barbershops and health, but a brief review of the literature will uncover, you ready for this, Renee? Centuries of evidence dating back to the humble origins of dentistry and surgery. Now, today, those prestigious specialties are far removed from their humble origins in past centuries, but barbershops are a place, have historically been a place for medical care. So while I'm grateful that the medicine has evolved, there is value in remembering the connections between the two. So barbershops and salons are places of connection, conversation, and community. Barbers and stylists have the trust of the people in their neighborhoods, and important conversations of the day are often discussed and debated in barbershops and salons. So it makes sense that we think back to the original meaning of that red and blue barber pole you see behind me here, and make barbershops and salons a place where health conversations and interventions can take place. About 5 years ago, one of the most important studies was published in the New England Journal of Medicine, demonstrating that you could control hypertension through a barbershop intervention. And hypertension is a major source of morbidity and mortality in the Black community. Now, unfortunately, when we do those kinds of clinical trials, Renee, and we find success and we publish them in our big journals, we then go back and do it again. And the community doesn't actually see it implemented. So I'm at the point, Dr. Carter, Dr. Brathwaite, and all my colleagues here, it's time to take action on what we know. We will never have perfect science, but we know now more than we've ever known about how to actually prevent these chronic diseases. Now it's time to do it and to enlist partners that may be non-traditional partners, but partners nonetheless, in building the kind of trusted bridges we need in the communities we should be present in.
So how do we get, for those that are listening, community members, how can they get involved in encouraging this?
Well, let me do one little commercial, and then I'm going to be quiet. Every Thursday, we have what's called the Cutting Edge Zoom Town Hall. And it all came as a result of COVID. So that's the other silver lining. Many of our community folk now are in these Hollywood squares, and now we can bring them together with the Dr. Carters and Braithwaites and Manns and the other folks we have here and have that kind of conversation and co-create a new future together. But if the conveners that brought us together go away because the contract's over or whatever it is, then the people will feel abandoned. And that's what we have to guard against. Do not abandon them. They're looking to us for guidance now.
Yeah. And kind of back to kind of what Dr. Brathwaite said about sort of individual responsibility in this setting, it's also having the community take ownership as well. Take ownership of this idea and saying we're not going, we need the partnership with the medical community, but we are demanding, this as a community. So, yeah. Let me check. Kyla, are there any questions that have come in that the audience may have? Because I always have questions, but I'd like. And okay, not yet, she said. All right.
If I can make a comment on the last question, I think
yes, please.
It can be helpful to try to identify what are the kind of intrinsic community groups, organizations, locations. I mean, the barbershops and salons are one example of kind of a nexus or hub in the community. I think the churches and faith institutions are another potential hub. Could there be a health aspect to the dreaded HOAs that some of us have to deal with? If those kind of groups exist. So just ways in which the community naturally comes together. Can we put a health lens into that and then use that as a fulcrum to say, okay, can we talk to local business? Can we talk to the county health department? Can we talk to the local hospital and all the other people who might be able to link into that and try to build that coalition in those very small spaces that even I think are going to have to be smaller than zip codes to really kind of work out some of the problems that people have. So we really get to those very unique needs that some of them will have to have addressed.
Yeah. I think that sometimes some of the greatest ideas start so small, infinitesimal, right? And it just grows. So yes, there's power at grassroots level. Isn't that our history as Americans? All right, here's the question. How can COVID lessons be applied to HIV prevention and care? There we go. Who would like to tackle that?
Well, I would just say, and then I'll throw it to the physicians. I think that the things that we've done that have been working in our African American and Latinx communities have actually come from the playbook of HIV/AIDS. That's where we got the, going into the bars. That's where we got, even the Black churches. So hold on, I got to show you something here.
Okay. Yeah. Well,
the art that has come out of HIV. We be mindful that we do not have as much time yet. Okay.
Yeah.
This pandemic has been months.
Yeah.
2 years is nothing.
Yeah.
So we don't have the equivalent of the AIDS quilt. We don't have the equivalent of a lot of the arts. Remember when Broadway went silent, went dark to raise awareness about
That's
HIV?
right.
Okay,
Yes.
That's because that community owned it. They embraced it and they said, we're going to save ourselves. That's what Black folk and brown folk need to do with this pandemic. Create our own art, create our own messages, and own this so that we can control how we manage it.
Yeah.
That's just my 1 cent.
Thank you.
Could I ask a question?
Please.
I think it could be instructive because we hear a lot about justice and health, and this might be the time for you, Renee, to give us some sense of how can we incorporate that concept of justice and right into building healthy communities. Sometimes,
yeah, I think this is a good first start, right? No, but go ahead, Dr. Brathwaite.
I'm saying that sometimes we are less clear about the concept, and hence the actions that should follow.
I see.
And not
Yeah.
necessarily.
Yeah,
ahead.
is the tail wagging the dog or the dog wagging the tail, right? Kind of what I think Dr. Jones said about the community has to be involved at the beginning. I think Dr. Carter said that we have to be at the table for, algorithms or policies, et cetera, et cetera. Yeah. This whole, the whole conversation about justice is so multifaceted, right? It is layered, but it is not siloed, right? And that's what I think, as human beings, we like to keep things neat, but it crosses over, just as I think it was probably Dr. Mann talked about. I think everybody mentioned it, right? Housing. I know that Ms. Hines mentioned it. All of these things are interconnected. All of these systems that we are seeing, some were built on inequities from the very beginning. And so, this all impacts. So, as a good lawyer, I have not answered your question. I've just talked around.
Well, as an attorney, then that critical race theory comes out of the law, and the effort to understand these social determinants and structural racism. You see the pushback now to make sure that doesn't happen. We got to be ready for that.
All right, and it's very interesting. We had conversation last night. See, I work so many nights, I don't remember, but really talking about the truth is the truth, right? And we can't be afraid of the truth. And only with truth do we then have reconciliation. Only in truth do we have better health outcomes. Only in truth do we have all of these different, to Dr. Brathwaite's, injustices corrected. So, it's talking is the first step. Listening to each other is the first step.
The former mayor of Tuskegee, Alabama, Omar Neal, has a saying that we all are possessors of some truth, but only when we come together and have this conversation and share do we find the truth.
Yeah.
I think there's something to that, but we got to figure out how to have these conversations and disagree without being disagreeable to one another.
That's right. Well, stay tuned. The Office of Human Rights, we're planning something in about a year and a half. We're on this quest. It's called Freedom Stories. Here's my little commercial. So it's based on the book Wait a minute. Where's my book? Because my computer's sitting on it. It's called A Question of Freedom, written by Dr. Will Thomas III. And I urge all of you to read it. It's about slaves in Prince George's County before the Civil War and how they sued in the court for their freedom. And it talks about all of this. And we are hoping to at some point have sort of a truth and reconciliation at the end of this 2-year journey. But Mark Hannington, sorry, boy, that was bad. Mark Hannington is one of our frequent guests from Hawaii. Viewers from Hawaii. And this is his question. I was horrified to hear the NFL's demeaning algorithm. Are there other similar sport-based incidents? I don't know if anybody is aware. I'm not trauma, but does anybody?
Well, that got national news. It was a whole movie, and so we got into it.
Yeah.
The kidney issue you raised. I've been going to nephrology meetings. They've been talking about these for years, and finally, legislation. Okay, how about the father of gynecology? Yeah. Okay, the father of gynecology. There's statues to the father of gynecology in Mobile, Alabama, and at one point in New York City, or was it Philadelphia? It may have been New York. But my point is that statue was removed. There's a reckoning going on right now. Just as you see the reckoning with Civil War, there's a reckoning even in the health field. At the University of Pittsburgh, where I was on the faculty, the building we were in was named after Thomas Perrin. It was Perrin Hall. Well, Thomas Perrin was the Surgeon General of the United States who oversaw the U.S. Public Health Service syphilis study done at Tuskegee. That the students, Dr. Brathwaite, demanded that name be changed from their building. They did not want to come. See, so this next generation coming up, they're not as tolerant of the injustice. They're not as patient for the incremental change. And I think we need to accelerate what the pandemic has taught us. So there are many algorithms, Mark Hannington, that we don't even know about that are discriminating against people of color for a variety of reasons. And it's going to get worse if we don't recognize that the humans programming those systems impact their bias in those systems.
Yeah, but knowledge is the key. And if you don't know the truth or knowledge, then we continue. Well, I had a lot of other questions to ask. For instance, and we don't have time for the answer, but how does sort of stress affect generations? Even if it's 3 or 4 generations from sort of these stressful times, and you now live in, the zip code that affords all of the things that money can buy, and you have all of the the education and the health, but yet it seems to reach forward and still grab you. So we'll have to have everyone back to really talk about some of these other things. We really, really want to thank all of you for lending your expertise, your time with us this evening. As I said, sadly, we are out of time. I want to thank everyone that tuned in to listen. And I hope that those listening have perhaps taken a little seed that has been planted, and we want the seed to grow. And I'm so sorry, I did turn my phone off. Yeah, okay. That the seed planted, that it grows, that, the power sits with us as individuals, as communities. And if we want to have better health outcomes, if we want to get rid of health disparities just as one system, we absolutely have that power. So I hope something that either Dr. Mann said, Dr. Thomas, Ms. Hines, Dr. Brathwaite, Dr. Carter, or Dr. Jones said resonated with you, and that will get you to take the next step, not just to listen, but to put this into action. So that's what I'm asking for those who are listening to do. We want to thank the library system for their partnership in this event. I especially want to thank Fatima Mahmoud from our office, the Office of Human Rights, who really was the driving force in putting this event together. So thank you for everyone for your time, your energy tonight. And again, we really, really want to thank you. And we hope that this is not a one and done, that we really begin to think about this and figure out how we all can work together to really change outcomes. So thank you all for joining us. Everyone, please stay safe. And Dr. Thomas would say, wear your mask. Dr. Mann would say, wear your mask. I am wearing my mask. Thank you very much.
Who are you sharing air with? Be careful out there.
That's right. Everyone have a wonderful evening. Bye-bye.
Thank you.
Bye-bye.